الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. الحمد لله رب العالمين. جزيل الشكر والتقدير للأستاذ الدكتور خالد مغربي لتفضله بوقته الثمين وجهده، وتفضل علينا وبإذن الله بمحاضرة تكون استثنائية about ARDS, mechanical ventilation in ARDS, or the ventilation management in ARDS, from the basic to the update and guidelines. Many thanks, and I am so pleased and so honored to have him today. My great pleasure and honor to have Professor Dr. Ahmed Madi as a moderator for our scientific committee today. Welcome Dr. Ahmed, welcome Dr. Khaled. God bless you، وما تحرمش من حضراتكم ابدا ابدا، وان شاء الله يوم استثنائي. متشكره جدا جدا لحضراتكم. اتفضل حضرتك يا دكتور احمد، قدم الدكتور خالد.
بسم الله الرحمن الرحيم. يعني طبعا والصلاه والسلام على اشرف المرسلين وسيدنا محمد صلى الله عليه وسلم. كل الشكر طبعا دكتوره صفاء. Thank you so much for دكتوره صفاء هلال. يعني I'm really impressed with her let us say outstanding activity. She's really heroic. She's really highly active in the educational training, and ان شاء الله يجعله في ميزان حسناتها وميزان حسنات الجميع باذن الله ان شاء الله. شكرا جزيلا دكتوره صفاء. It is my pleasure actually to present يعني can I say my senior consultants from day one. I'm here in Saudi Arabia since long time back. Dr. Khaled Maghrabi, he was my consultant in my area. I was at that time senior registrar and fellow, and by the way, he was my examiner also in the fellowship program. Dr. Khaled Maghrabi, one from the eminent intensivists in the kingdom and on all Middle East, I can say. أهلا بك دكتور خالد. I just give me brief just to show you, to tell them about you يعني briefly from my own. I don't have any paper or CV for you. I'm really delighted to present. I can say one from the founder of the residency program in the kingdom since 2015. And he has two subspecialties. He's eminent in both, يعني internal medicine subspecialty and intensive care. Dr. Khaled is examiner also in the Saudi Commission for Healthcare Specialists for Internal Medicine, and he was director of the program in King Faisal Specialist Hospital long time back. And he's now on the as ICU consultant in King Faisal Specialist Hospital and Research Center, one from the, let's say, class A in the Middle East of the hospitals and the research center in the worldwide. Dr. Khaled Maghrabi, of course, he passed all the residency program, fellowship program in King Faisal as well as in Ottawa in intensive care, as well as also Arab board long time back. Has a lot of interest in the ICU, and he's examiner, of course, of the Saudi board as well as Saudi fellowship program and the Saudi Commission for Healthcare Specialists. He's the one also of the big, let us say, founder also. Let us say he's in establishing the Saudi Critical Care Society in the kingdom. Really, his activity in the education is not limited to Saudi Arabia, but also expanded a lot. He has a lot of activity in Gulf countries, in Sudan, in Jordan, in Egypt. Really, I'm proud to be his fellow at one time before, long time. Dr. Khaled Maghrabi, thank you so much. And he will talk with us today about one from the very, let us say, hot and the common topic in all ICUs worldwide. All of us knows acute respiratory distress syndrome. It is a hot and big topic in ICUs worldwide. يعني usually ICUs between sepsis and ARDS. ARDS one from the big topic, and debating a lot of researches, lot of trials, lot of guidelines talk about it. I think he will take us in a very, let us say, a journey of ARDS from basic until ventilatory support, literature, evidence-based guidelines. Inshallah, I'm expecting a lot, as usual, from my senior consultant, Dr. Khaled. Kindly, for all the attendees, it is really official talk, but feel free to write your questions in between. Just drop it in the chat room at any time. I will deliver to Dr. Khaled, and we will try even to have like in between the session, we have like some break to discuss with him the questions you will deliver in the chat room. Feel free to drop all your questions in the chat room. Thank you so much and welcome. And Dr. Khaled.
السلام عليكم ورحمة الله وبركاته. مساء الخير. Ahmed, thank you very much in illustrating how old am I compared to you. And I'm really pleased and glad to be with you tonight. A lot of thanks for Dr. Safa Hilal for her invitation and give me this chance. Actually, talking about ARDS, mechanical ventilation, I thought it is the bread and butter of critical care medicine, and anybody in critical care medicine, probably among the first thing that we learn is how to ventilate patient with hypoxemic respiratory failure, and basically a patient with ARDS. But what I'm going to do, we will have a quick review for the important points, and I'm trying to link things together. And my main aim is to link the basic with the clinical. So as intensivists and people treating ARDS patient, we have to understand why we are doing things so we can do it rightly, and we understand the rationale of what we are doing. I'm trying.
Now it is clear.
So,
yes.
Bismillah. So we'll talk about multiple aspects in the management and mechanical ventilation or ventilation in ARDS. And my talk will be limited only the aspect of mechanical ventilation. I'm not going to talk about other non-ventilatory support. We'll not talk about other things. And many of the things that probably you did hear it before, but we try to link things together. And as Ahmed mentioned, maybe later on you can post your question. One of the important things I would like to go and talk about it is the pathogenesis. Why you have to understand the pathogenesis. Basically, the mechanical ventilation is a supportive therapy for a diseased alveoli or a diseased lung. So we have to understand what's happening there. So the support would be adequate, or the support will be beneficial for the aim that we would like to improve for the gas exchange. And if you look at the pathogenesis of ARDS, you will find multiple resources with good illustration in the literature and in the internet. And I selected this one to go through few things that I would like to explain. So normally, there are millions, of course, of alveoli, but if we look at one unit of the alveoli, it is an air cell which is filled with air. So number one should be filled with air to carry the function. The other thing, we can see that there are a membrane, which is thin membrane with cells that produce surfactant, that the alveolar type 2 cells, surfactant layers that keep the alveoli open most of the time, and then lymphatic system that drain the excess fluid there. In addition to that, a basement membrane. So this is the basic structure, and then it's in a very close vicinity with capillary, so the gas exchange occur at this level for the healthy one. Once a process happens and cause inflammation of the lung, and that progress to ARDS, either with endogenous cause like pneumonia or exogenous cause like pancreatitis, burn, or trauma, then an inflammatory process will happen, and this inflammatory process will lead to the exudative stage, which is the first stage of the inflammatory process. So now, instead of having air cells filled with air, no, it will be filled with some fluid. And this fluid is not a hydrostatic, simple water fluid. No, it's a fluid that contains platelet, a fluid that contains active immune cells, and contain dead injured alveolar cells, inactive surfactant, fibrin, and multiple mediators. In addition to that, that thin membrane that usually ensure adequate gas exchange will be really damaged. The hyaline membrane surfactant will be deficient. There will be some thrombosis in the capillary, which is more prominent in ARDS-related, COVID-related ARDS. So now you can see that the cell has a problem in its content, the ability to clear fluid, the ability to generate surfactant, and probably the ability to exchange gas. And the next stage in the process will be the proliferative stage. And the proliferative stage is some sort of a recovery stage where the cells or the alveoli start to recover, fluid will be absorbed, and then will be regeneration of the epithelial cells, removal of the cytokines. And if this continues to happen, probably the patient will recover. If not, then we go to the third stage of the disease, which is the fibrotic stage, where more fibrous tissue will be there, deposited in the interstitium, deposited in the alveoli, and then the patient will be more hypoxic, and probably we can see at stages with severe ARDS. Of course, we don't select where we found the patient, but the patient go through this process, and you can imagine at what stage you can find your patient. So when we have a diseased alveoli like this alveoli, we would like to help this alveoli, support this alveoli with mechanical ventilation to perform the gas exchange and to compensate for the failure. Important point: for any organ to fail, they have to compensate. Nobody will fail, or no organ will fail before the trial of compensation. So when the patient reach to a level that he has hypoxemia, okay, that means he tried to, or the lung tried to compensate, doing all the things that they can try, with increasing the tidal volume, with increasing the respiratory rate, using the accessory muscles, all these things that to help to support these diseased alveoli, and they could not. And then here we have to intervene and support these alveoli with some mechanical support. One important issue I would like to emphasize and keep this in mind, it's very simple. So the alveoli is supposed to be filled with oxygen. The oxygen will pass from the alveoli with no problem, but it has a gradient between the alveoli and the capillary, and this gradient goes abnormally up to 10 and increase with age. So the air sac is filled with air, filled with oxygen. The oxygen will move freely to the capillary. The capillary, the blood in the capillary will move it to the lung, to the left atrium. And then the CO2 will go pass with no gradient. So the CO2 will pass freely, no gradient, and then stay in the alveoli. It will be moved, and we need a minute ventilation to move this CO2. So in a diseased alveoli, either ARDS, pneumonia, or pulmonary edema, what will happen? Not all the airspace will be, or the air cell will be available for gas exchange. The gradient probably will increase. So let's say usually if you have 100 molecules of oxygen, 90 will pass freely with no problem. But in a diseased alveoli, you may have about 80, 70, depending on the severity of the disease. And then the CO2, when it comes and stays there, maybe you don't have adequate minute ventilation or tidal volume that move the CO2. This is important. And I want you to keep in mind, just to imagine that what you are doing with the mechanical ventilation, you just imagine the alveoli, how I need the alveoli. I need an alveoli which is open, had enough oxygen, and it will have the time to move the oxygen from the alveoli to the capillary. And when I would like to support, I have to support with important principle, which is the first principle in medicine, doing no harm. My support should not generate harm and inflict harm to the alveoli. And this is, I think, the main point in our ventilation of ARDS. So this is an important point. So if you have, and I will come to this, this diagram, when you have a diseased alveoli in ARDS, you would like to ensure that you deliver a gas in an amount that will be filling the alveoli, compensating for the problem, for compensating for the decrease in the amount of air in each air cells or each alveoli, and try to avoid two things. I will try to avoid you going to the part there is which not all the alveoli are inflated adequately, where you have some atelectical trauma, And the atelectic trauma, basically, if you have atelectasis here, that the alveoli will be collapsed, no much of air coming to these alveoli. So in addition to the infiltrate to the fluid that presents in the alveoli, it is collapsed and there is no space for that. So I would like to avoid this one. And I would like to avoid going to hyperinflation and overdistension of the alveoli. So the alveoli will be distended, filled with air in addition to the infiltrate. This also may cause a problem, especially with repeated inflation deflation. So when you have an alveoli goes between inflation, deflation, you increase the shear force injury basically at this point, and this will lead to what we call as a biotrauma, which is not seen, a part of the trauma not seen, but lead to the release of cytokines and inflammatory mediators that will go back again and cause more problem to the alveoli, and we call this is villi or ventilator-induced lung injury because of this repeated inflation and deflation of the alveoli. It's important that in addition that you have decreased compliance of the alveoli of the lung, increase the physiological dead space. What will happen during this period, you have a lot of biological alteration that include increased concentration of factor like growth factor, interleukin-8, with the release of mediator like tumor necrosis factor, interleukin-6, interleukin-1, and more recruitment of inflammatory cells like macrophages and neutrophil. So this will lead to some release of the inflammatory mediators to the circulation. And when it's released to the circulation, it will lead also to some sort of organ failure. And this is these patients, they can go into other organ failure and actually leading to the death of the patient if things are not corrected in a way. So this is the pathogenesis. So what I have alveoli, which has a disrupt membrane filled with the fluid. There is competition between the fluid and the air there. I have to compensate for this, but I would like to avoid doing harm by collapsing the alveoli or offer distension or have repeat opening and closing of the alveoli. And this is what we like to do with mechanical ventilation. Important thing that we don't see the alveoli. Okay, this is the pathogenesis at a microscopic level. But how we can this reflect on practice? To reflect by knowing the lung mechanics, and all of us probably know the pressure volume loop of the lung. Basically, when we put some volume of air in the lung, it will generate a pressure. And this is the diagram related to it. And we assume this is reflecting what's happening in the alveoli. Okay. And as we said, we would like to prevent atelectative trauma, and we prevent volutrauma with overdistension of the alveoli. And we would like to ventilate the lung and the alveoli at this level, at the safe window, which is the window between that prevent the alveoli from going collapsed and prevent the distension. How we know, how we do these things, we will come to this point. And this is why people, they think that modalities like high frequency oscillation, ventilation, and airway pressure release ventilation is safe because you think that you are ventilating the lung in this area, which is safe, prevent overdistension and prevent collapsing of the alveoli. So this is one of the important principles that we assume. So we have lower inflection point and we have upper inflection point. Below the lower inflection point, I have atelectasis. Above the upper inflection point, I have overdistension and volutrauma. So I would like just to imagine that these disease alveoli that need my help, need my support, I would like to keep it open, okay? And to keep it open, I need to keep the pressure above the lower inflection point, and I have to distend the alveoli enough to deliver oxygen, but should not be over distension below the lower inflection point, and we ventilate the patient like this. One of the important thing, and you keep it in mind, the equation of motion. Basically, I have a volume and I have a pressure. So the equation that gives me the relationship between the volume and the pressure, it is the equation of motion, we call it, which is the relationship between the pressure and volume. And the other factor affect this will be the lung compliance. It could be the respiratory system or the lung itself. Okay, so as we increase the volume, the pressure will increase. As we decrease the compliance, the pressure will increase. Then the other part will be related to the flow and respiratory resistance, the airway resistance. So when you increase the flow, the pressure increase. When you increase the resistance, the pressure increase. So this pressure volume loop will be variable based on the flow. For example, if you change the flow, you change how the pressure volume loop will happen. So for this, let's say we take this point of volume, we look at the pressure. So once you increase the flow, it goes and increase more pressure, and we can see it. If you change the setting of the mechanical ventilator, you increase the flow, the pressure will go higher. So this is one important thing to keep it in mind. So the loop is not fixed, it will change according to what you are doing, and these are the factors leading to it. In addition to that, if you have a diseased lung with ARDS, we know that ARDS is not a homogeneous disease. It is a very, very heterogeneous disease. There are areas where it's complete collapse of the lung, of the alveoli. There are area of partially collapsed or diseased alveoli, and area with normal alveoli. When you apply pressure, the pressure volume loop is not the same. So in this area, because it has decreased compliance, the same volume give you higher pressure. In this area, which is very well aerated and ventilated, the same volume will give you a lower pressure. So again, not the pressure that we see, you don't know what's the effect in other parts of the lung, it's different. So for that, we have the principle of the baby lung. In ARDS, they tell you not all the lung available for you for ventilation. It is a baby lung. Part of it is completely not contributing, partially contributing, part will be fully contributing to gas exchange, and this affects the mechanics of the lung. And this is why probably if you make this area homogeneous, more homogeneous, by recruiting the alveoli, and one of the best methods of recruitment by basically with the prone position, you improve the variability in the pressure volume loop between different parts of the lung. So the differences between the loops in different parts of the lung will be more homogeneous. And we'll come to the prone position later on. This has been also illustrated using advanced method like electromyography and looking at different parts of the lung, and it shows here, for example, where different aeration of the lung is there, and the pressure volume is different based on the area of low inflation and or recruitment or airspace that has more air to the airspace that has more fluid. So this is important point. When you apply mechanical ventilation, consider that there is variability on what you do on the alveoli. So what you are doing could be harmful to some of the alveoli and could be useful to other alveoli. And this is again an illustration, if it is clear, I hope it's clear, that in high frequency oscillatory ventilation, we would like to ventilate above the lower inflection point in a safe zone, and it shows there how the alveoli will open, and to correlate this again and to keep it in mind, hope it will run. We will illustrate it in another graphic format, the relationship between where we are ventilating the lung and its relation to the pressure volume loop and how we can imagine the lung. So when we ventilate below the lower inflection point, you can see Here, the lung is atelectatic, not inflated. Once you start to go above the lower inflection point, you ventilate the lung, good part will be ventilated. And then if you go to the distension part, it will be over distended, and then you have the inflation part and the deflation part. What I would like to do to keep the lung reasonably inflated, reasonably contributing to the gas exchange. So this is an important point, and this is one of the things that I have to keep in mind. All the time also, with keep in mind the alveoli. I need to keep the alveoli open, distended, has oxygen. And the other things that I correlate this alveoli, which is open, contain oxygen, with pressure time curve on the mechanical ventilation. If you have a pressure curve, you have the time. So the pressure time curve, the mean airway pressure form for me or will be analogy for the alveoli, which is will be distended for adequate time, containing more oxygen. So when we'd like to improve oxygenation, I would like to have more oxygen in the alveoli, keep it distended for longer time to give the oxygen more time to transfer from the alveoli. The same thing for the mean airway pressure. The mean airway pressure should be adequate. So when we'd like to improve oxygenation, I increase the mean airway pressure. How I increase it by increasing the time, and increasing the pressure. How we ventilate patient with ARDS? I think if you ask any one of you, I think the golden word, and I would like to hear it when I ask how we ventilate a patient with ARDS. It's a simple thing. It is a very known now for more than 20 years. We have to do protective lung strategy. What is protective lung strategy? Why we say protective lung strategy? Because in the past, before the 2000, yes.
I think I just want you to give a message for all of them, because I notice now our even residents, they are not focusing on the pathophysiology or physiological process or how it will be reflected in management. The importance of going through the inflection points, pathogenesis, heterogeneity of the ARDS, even inflammatory process you had mentioned early. I think it's very important for everyone to know it in details, because it is reflected on clinical base, not only to know how ARDS be vented, but even though these basics will be affected their performance in clinical practice. Are you agree with me, or?
I think this is the main point I would like to deliver in this lecture, Ahmed. As specialized in this field, we have to know the basics. So when we do something on the bedside, we know what does it reflect. We have to have the imagination. We have to know what we are doing to the lung. I think it's absolutely, it is the most important point.
I agree with you. Thank you.
Right. So when we say protective lung strategy, before the year 2000, we were ventilating patient, and basically the mortality was high in these patients because different things. And before 2000, and maybe early in the 2001, 2002, when we practiced, we saw a lot of barotrauma, which I don't see these days. So we are doing harm to the lungs because we are not ventilating in a protective way. What's the protective way? That you avoid villi, ventilator-induced lung injury. You avoid barotrauma. You avoid injury of the alveoli. And in the past, people, they used to use tidal volume of 10 to 12 ml per kg. And maybe they don't use ideal body weight. They use actual body weight. So these things change. And now when we say how we ventilate a patient with ARDS, the answer will be by, okay, it's hanging, by protective lung strategy. Usually when I talk about protective lung strategy, I will say, okay. I will say there are few pillars in protective lung strategy. And this graph, it will find it in different way. one of the important basic thing that I would like to make it a habit. If you say what is the ventilatory setting, how we ventilate a patient, the first question I will ask, what is the ideal body weight? Very important. The importance of the ideal body weight, that the volume of the lung is created based on the gender and the height of the patient, of us, of the human being. If I get chubby and gain weight, my lung volume after I get adult, it will not change. If I come thinner and slimmer, my lung volume will not. So what I have to ventilate is the lung volume, which is in the human being with the ideal body weight. So I have to calculate the ideal body weight. I'm not good in equation, but if you open your browser in any phone or any internet, you find it. If you don't have it, you have to calculate it in a simple way using centimeter or inches, and then this is the body weight. Then the other important point is really, as we said, we would like to ventilate with a volume that prevent atelectatic trauma, and we decrease the overdistension. So we choose to have a low tidal volume. Low tidal volume compared to what has been or had been used in the past. So we're using a tidal volume between 4 to 6 ml per kg ideal body weight. Which one I start? You can start at any point. You can start with the lower and you go higher. You can start at the higher coming down or in the middle, and then you adjust according to the plateau pressure. Why the plateau pressure? Because the plateau pressure, it is the pressure we obtain it during inspiratory hold, where is no flow in the alveoli. So if you remember the equation of motion, the flow multiplied by the resistance would be 0. So what reflect for me is the relationship between volume, compliance, and the pressure. So when I measure the plateau pressure, it reflects for me the pressure inside the alveoli. And we have to keep it at a safe level. What is the safe level? As been in the studies, it is less than 30 centimeter water. So you start at certain point and then you adjust it according to the plateau pressure. Of course, when you use a low tidal volume, there is a price to pay. The price, because the CO2 will come, stay there, need minute ventilation. You reduce the minute ventilation by reducing the tidal volume. So you have the hypercapnia. So I have to permit some hypercapnia to the degree that I maintain a safe pH. And then the other point, if you remember the alveoli, I need to keep it open most of that. I don't have enough surfactant in the alveoli. I have to keep it open with a continuous positive airway pressure, which is the PEEP. PEEP is positive in the expiratory, but it is actually a continuous pressure through all the cycle, during inspiration and during expiration. And then I have to keep the PEEP probably to keep the alveoli open even during inspiration. So the PEEP should be set above the lower inflection point that we mentioned in the pressure volume loop. So the PEEP should be set there. How I know? If you have tools like a bedside CT scan or electroimpedance, maybe it helps you, but really you have to try. How I try? You go with your PEEP and then you look at the relationship between the pressure and the volume and the compliance, and you choose the PEEP that give you the best relationship between the pressure and volume. The IE, if I'm using volume control, so I use the PEEP that will give me the best pressure for this set volume. Otherwise, if I'm using pressure control ventilation, I use the PEEP that give me the best volume with a set pressure. And then how I know this, you have to try it in your patient. And we'll talk about PEEP at this point. So this is important. So what are the pillars of low tidal volume or protective lung strategy? Low tidal volume, keeping the plateau less than 30, and use PEEP to improve oxygenation. And what you can use actually in the ARDS network study that it came the 2000 and changed the practice, this is the suggested table. You go with the PEEP according to the FiO2. But do you have to stick to this? You may try to start what you are doing and then you adjust. Important point, patients are they are different. So doesn't apply for every patient. So if you would like to do the best, you have to be at the bedside, try with your patient to see what's the best for your patient. Fine. So this is the study, the summary of the ARDS net, which was published in 2000, the year 2000 in the New England Journal of Medicine, and it was a breakthrough in medicine. It is among the most important article in critical care medicine, and it showed that when you use a low tidal volume, it improves survival, it improves discharge home, it improves the ventilator-free days with statistical significance. With a statistical significant here, and you can see from the graph here, this is the survival and discharge for the traditional volume. It's much lower. This is the survival, and this is the discharge. The discharge is more with a low tidal volume, and the survival is more with low tidal volume. Since then, we are using low tidal volume, and as time goes, it's proved that this is the way that we go. What we are doing in the past was harmful for the patient, and we have to stick to the ideal body weight. It's important. And then, as years time goes, in 2015, Amato, he used in an article published in the New England Journal of Medicine. What he did, he took all the studies looking at ARDS management, and then using low tidal volume, and he did a complex statistical method to look what are the things that improve survival in this patient, and he came with the recommendation to use the driving pressure. The driving pressure is the difference between the plateau and the peak, and he found that if you look here, one, that means no difference between the two interventions, but at the driving pressure of less than 15, we can below 15, we can see there is a difference. There is improvement in the survival and improvement in the outcome of this patient if the driving pressure. So in addition to what we are saying for protective lung strategy, in addition to the plateau pressure less than 30, I have to keep the driving pressure below 50, below 15. And it has been used also to set the optimal PEEP using the driving pressure. Right. And one of the other things we use to target a higher oxygen concentration, but now we accept a lower oxygen saturation, oxygen saturation in patients with ARDS, and this study compared liberal and conservative oxygen therapy in acute respiratory distress syndrome, and they found that conservative oxygenation between 50 to 57 did not increase survival. So we have to keep probably our oxygenation at the target between 90 or 88 to 92. I think I missed one slide. 92. So the target, probably you should not go for a very high oxygen saturation. Your target for oxygen should be lower. So sometimes we would like to do more in the mechanical ventilation to get a higher oxygen saturation. You should not do this, but also keeping it a lower oxygen will not improve survival, but going to higher oxygen saturation also will not improve the survival. So we should not do harmful ventilation to keep the oxygen saturation at a higher level. Then studies come to the PEEP. Shall we use high PEEP or low PEEP in ARDS patients? And then this study published 2004 in New England Journal of Medicine, and basically they compare two levels of PEEP, high PEEP and low PEEP group, and they look at the outcome. So if you look at death before discharge home, there is no difference between the high and low PEEP. Breathing with assistant, there is no difference. Number of ventilator-free days, there is no difference. Number of days spent in the intensive care unit, there is no difference. Barotrauma, there is no difference. Number of days of circulatory coagulation, hepatic renal organ failure, there is basically no difference. So using higher or lower PEEP doesn't make difference. But when we go to systematic analysis and systematic review, meta-analysis of different studies looking at higher or lower PEEP, and they compare what they call low PEEP with a PEEP of above 5. Even when they use no PEEP, they mean no PEEP. It is minimally 5 of PEEP. And if you look here, basically about here mortality in ARDS patient, there is an improve in the outcome for the patient who improve with higher PEEP or with PEEP in terms of oxygenation. So if the patient you apply PEEP and oxygenation improve, this application of PEEP would improve outcome. So if you are increasing the PEEP and it's not improving oxygenation, it's unlikely to improve the outcome of these patients. So it's important to look at this point. And if you look at, again, they look at the ICU mortality. So I think that was an hospital mortality. This is the ICU mortality. Again, if the patients, the group, they analyze the group who have positive oxygenation response to PEEP, the outcome of this patient is improving and favoring the utilization of higher PEEP. To conclude, again, no, this is the barotrauma. So you can say, okay, if I use high PEEP, I will expose the patient to increased risk of barotrauma. This meta-analysis telling you if you are using high PEEP, it usually will not cause a higher rate of barotrauma. And to conclude here is basically high PEEP did not improve the outcome in these patients, but the subgroup analysis showed that high PEEP decreased hospital and ICU mortality in ARDS patients with a clinically objective positive oxygen response to PEEP. Okay. Right. Now, so how I ventilate a patient with ARDS? I ventilate with protective lung strategy, which include low tidal volume, keeping the plateau less than 30, keeping the driving pressure around 15, and keeping utilizing PEEP and in these patients, and to allow some hypercapnia in this patient as long as the pH is allowed. But sometimes patients, they don't improve. If the patient is not improving with these basic principle of mechanical ventilation, these basic principle that I'm trying to keep the alveoli open and doing what we said about the mechanical ventilation, what I should do, I have to try other supportive measure. What other supportive measure? Non-ventilatory supportive measure, paralysis, muscle relaxant, using diuresis and reducing the volume, treating with bronchodilator, treating with antibiotic, treating with underlying cause. I check if there is something preventing the patient from getting benefit of what I'm doing, like a patient asynchronous to the mechanical ventilation, or the patient with, because we are increasing the rate to compensate for the minute ventilation, the patient has O2 PEEP, or sometimes patient, they don't like volume control. I try to switch the modes between volume control, pressure regulated volume control. I may try NAVA, I may try ABRV, different things to see if it works. And if you found that no, probably what's happening is because of the disease severity and the severity of the ARDS, what I should do at this point. There are few things you can try, and we'll show it here in the mechanical ventilation. And one of the important things I think I would recommend to do and try, and this has been proven over and over to be beneficial. And when we mentioned and we talk about the basic, when you do Browning positioning, the Browning positioning, basically, I recruit more alveoli that reside in the dorsal part of the lung, and improve the homogeneity between the air cells. And the relationship between the volume pressure curve will be probably more linear, more smooth in this situation. So this is related to the basic. And it has proven, if you look at images, if you have looked at CT scan images, if you look at electroimpedance images, it shows you when you prone the patient, This is supine. We put him prone. More aeration happen in this area, the dorsal part near the spine. And when you put the patient back to supine, it goes back to be less aerated part. So prone is very important thing that we have to keep in mind. And one of the landmark studies for prone, which is the PROSEVA, which published in 2013. And basically, they included patients with severe ARDS with VO2, FiO2 ratio less than 50, intubated for more than 36 days. They are stable hemodynamically. They are not with any contraindication like pulmonary hypertension or intracranial hypertension. And they enrolled 466 patients into two groups, the prone position group for 16 hours, okay, and no proning. And what they get, a remarkable benefit for ventilator-free days within 20 days, 14 to 10, with significant p-value. More successful extubation in the prone group with a significantly statistically significant difference. Similar rate of tracheostomy and improvement on the mortality with a statistical significant difference. So this is a very good thing in terms to prove that prone positioning is something helpful. But we have to keep in mind that PROSEVA, their definition for ARDS, they optimize the mechanical ventilation for 12 to 14 hours, and then if the patient has BF ratio less than 150, they consider this patient has severe ARDS, include them in the study, and they consider paralysis and proning before that. So this is important to keep in mind. So proning is not the first thing that I will go, but if the patient has severe ARDS, I paralyze the patient and then I will prone the patient. And in different studies, it's shown here, like if you can see the letter SM, this is supine and this is prone position. So during supine, BO2 ratio will decrease. During proning, it increase. I could put the patient supine, decrease. So it improves oxygenation for that. In the past, people, they used to do proning short period, but now when you prone the patient will go to about 16 hours based similar to the PROSEVA. Why prone will improve oxygenation? We said about more recruitment of the alveoli in the dorsal part, but other theory that because when the patient is supine, more part of the heart will compress on the lung. So we improve the ventilation distribution by relieving that part. Smaller volume of lung is dependent. So we increase the functional residual capacity and reduce the shunt. Probably when we prone the patient, we decrease the pressure of the abdomen into the chest and improve secretion mobilization, improve maybe resolve delivery, and then hence we improve the ventilation, we improve the VQ mismatch in this patient. But definitely it improves oxygenation and it improves the outcome of these patients. And if you look at this table, it will tell you there are 5 studies they use prone positioning, and it's starting from 1996 to the 2011. And the duration of prone, you can see, started 7 hours for 5 days, 9 hours, then we go to 16, 17 hours in the PROSEVA. But the remarkable thing that the use of low tidal volume was in the PROSEVA. The previous study, they did not show a difference in mortality between the two groups, but PROSEVA, it showed a significant change in mortality. Why? Because they use a combination of low tidal volume and proning. So in patients who are not responding to protective lung strategy, we paralyze the patient and then we prone the patient using low tidal volume plus proning. This will improve mortality in these patients. So this should be the practice, and we have how we go. Again, this is another meta-analysis published in 2017 looking at prone positioning, and this is basically looking at the outcome, the mortality of patients when they are prone, and it favor prone. Even they included some studies before the PROSEVA in 2013. So if all of the previous study used probably low tidal volume, maybe the result will be different, and it will be favoring more the Brown positioning. And this is again to illustrate when the patient is supine, see how much of disease lung will be the dependent part. When you flip this patient into a Brown positioning, you aerate more of the lung, and you can see here even the area which is over aerated will be more when the patient in Brown it's over aerated when the patient is supine. When you do the Brown, you get more homogeneous ventilation, less over aerated, less poorly aerated lung compared to the to the supine position. Gattinoni, if you listen to Gattinoni, he is a believer that how I know the patient will respond to Brown. Of course, oxygenation is one guide to tell you, but CO2 responder, decrease in the BCO2 with Brown position is a predictive improved outcome in acute respiratory distress. The message from this study, when you Brown patient, you don't only use oxygenation, but look at the CO2. If the patient clears CO2 more, that means the patient is responding to Browning, and this is important message to be looking so independently of the ventilator setting, which was maintained and modified. The patient who reacted to Brown positioning with decrease in the partial pressure of CO2 had a better outcome than the patient who did not. The BCO2 change per se does not seem influence the outcome. I think outcome, we have to be careful to measure everything by looking at the mortality, because this needs a lot of work. But if it improves gas exchange, for me, that improves the physician intervention, the changes that may cause harm for the patient. Right. Then we move to another thing. As we said, remember the alveoli.
Would you like to keep the questions at the end, or we can give you some break in between for some quiz for each section?
زي ما تحب انت المودريتور يا احمد.
I think we just want you to take rest in between. Because I think it's very long. Yeah, you're covering all of the aspects of the ARDS. Let us have one. For Browning, for example, I think we cannot leave the Browning without talking your experience in COVID. Of course, especially this one, it is different and increasing the popularity of the Browning worldwide, right?
Of course, Browning in COVID now, I think COVID confirmed that Browning for ARDS is useful, and Browning now, COVID helped us to say Browning can be done on awake patient, and it's useful, and it may help the patient with respiratory failure to progress and go to severe ARDS. So I think COVID illustrated this point very, very well. And you may see further publication coming confirming this point.
And I think there is one landmark trial for COVID Browning by Dr. Walid Al-Hazzani, of course, the Saudi researcher in Canada, right? It will be like, I think we have it, even not affecting mortality, but improving in hypoxemia, and very, very eminent trial, multi-center worldwide, and a lot of patients from Saudi Arabia, a lot of centers, including in this trial.
This is what I'm telling. This is what I'm telling you, that it will come in the future. You can see that even in non-ventilated patient, Browning is useful. One of the things probably related to ARDS and ARDS management of severe ARDS, Browning of Ecmo patient on venous Ecmo. When they use Brown combination with Ecmo, they have a better decannulation rate and a better extubation rate for this patient.
You see, I'm agree with you, Dr. Khaled. Browning, just very wide extreme of Browning from awake patient until ECMO patient. All of them will get benefit from that. But I think also they have, once when anyone practicing, he has to have like own protocol, because it needs special trained personnel, the special places to do. It could be easy, it could be harmful also. It could be, if not done in proper way, right? I agree with me, I think.
طبعا هو Browning definitely it need a trained personnel. They need a protocol, and but it is doable. It is, when it's done rightly, it is safe. And if you look at the literature nowadays, not only we're talking about Ecmo, but even patient with tracheostomy. If the patient, they have tracheostomy, they do bronch this patient, and they found this is also safe when it's done the right way. Why we don't do bronch? Because the difficulty initially of turning the patient. But if you have the trained personnel, enough number of personnel, they can do it. And we should not have an excuse not doing bronch. There are few things you have to keep in mind, and you be ready for it. You prevent pressure injury. You look at the experience regarding feeding. You can feed this patient with no problem. People, they're worried about if something happened to the patient, like patient has barotrauma, you can insert chest tube in somebody who's prone. What happens if the patient have arrest? There are ways also how to resuscitate patient when they are prone, to start to initiate the CPR, and then how you flip them. All these people, they try it, and we should try.
I was believing before that you have to have this prone bed, which is almost more than million real. I think nowadays with trained personnel you can do it.
Yeah, for me, I think looking for those beds, it's very expensive. It's not available, and you could not really equip every hospital with such beds.
Thank you so much, Dr. Khaled. If you would like to continue, we don't have more questions.
As you like, Ahmed. شوف الشباب عندك ماذا. I don't see in the chat if there is.
We have one question in ABRV, but I think I postponed until we'll finish. Maybe we'll cover, not now.
Yeah,
yes.
we will cover.
Yes, right. I think so. Thank you, Dr. Khaled.
Okay. Inverse ratio ventilation. If we remember the alveoli, we said we need to keep the alveoli open, filled with oxygen, and give more time for the oxygen to go. Then we use the inverse ratio ventilation, and with that I improve the area under the curve. I improve the mean airway pressure during the inspiratory cycle by using inverse ratio ventilation. What's the evidence for inverse ratio ventilation? There are studies. There are 3 studies here, and they included a small number of patients. And what the first study concluded, that it is safe to implement inverse ratio ventilation in this patient with severe respiratory failure, and it improved oxygenation at lower minute ventilation, peak airway pressure, and PEEP requirement. The second study, Mercat, they have 8 patients only. They said the result in significant intrinsic PEEP, in IRV at a ratio that result in significant intrinsic does not improve oxygenation and enhance CO2 elimination, decrease cardiac output, and they doesn't exert any time-dependent effect. Third study with the same author, but this is that one. The first one was in 1997. Second one was in 2001. And they said in patient with ARDS, extending the expiratory time without inducing clinically significant increase in intrinsic PEEP doesn't improve arterial oxygenation, but enhance CO2 elimination. So there is no strong evidence to support the use of inverse ratio ventilation, but you can try it. As we say, patients that are different, you can try it safely in these patients and see if it is improving the oxygenation. And this is one of the methods that we are using these days to improve oxygenation, keeping in mind the basic principle of keeping the alveoli extended longer time to allow more oxygen to travel from the alveoli to the capillary, and improve the mean airway pressure and improve the oxygenation. Lung recruitment. I think we recruit lung with groaning, but we can also recruit lung using mechanical ventilation. Is this useful or not? So basically, the recruitment maneuver is a process of inducing an intentional transient increase in transpulmonary pressure aimed at reopening of non-aerated or poorly aerated alveoli. So what we do, we go increase the pressure in the alveoli for a short period of time, hoping that these collapsed alveoli will be open with this high pressure. But we don't maintain this pressure, the high pressure, for a long period. We keep it for a few minutes, and then we go back. The immediate expected benefit will be improvement in oxygenation and respiratory systemic compliance. Improve oxygenation because we open more alveoli, we allow more alveoli to contribute in the gas exchange, we improve the VQ mismatching, and also because we improve the amount of volume, okay, going to the alveoli, we improve the compliance, the system compliance. Okay, how we do recruitment maneuver? There are two major ways to do it. One of these ways that you go and put a pressure of 40 airway pressure for 40 seconds. How I can do this? You can do it in the usual mechanical ventilation, or the best way, you do it through ABRV. But how we do it? You change the alarm setting so the alarm will not continue alarming, and the mechanical ventilation, so increase the apnea time to more than 40 seconds. You decrease the rate, and then you put the patient on CPAP or PEEP of 40, and then no ventilation for 40 seconds, and then you go back. But when you go back after this period of ventilation for 40 centimeter water for 40 seconds, you have to increase the PEEP to keep the alveoli which open during this recruitment. And for example, if you are in a PEEP of 10, you can go to 20, and then you come lower. The other way is to go with your airway pressure, total peak airway pressure, to the level of 50 using PEEP and the inspiratory pressure. And you make the difference between the inspiratory pressure, the peak pressure, and PEEP is about 15 centimeter water. So you go, for example, from 25, the PEEP is 25 to and the peak airway pressure 40, you increase the PEEP to 30, you increase the PEEP to 35, you reach to peak airway pressure of 50, but the difference between the peak airway pressure and the PEEP is 15. You keep it for a while, for 1 minute, for example, and then you come down. With this, we're keeping also higher PEEP. So the PEEP here will be 23, 20, 17 to 11. And then you can do another recruitment maneuver later on. If you look at this study published in JAMA in 2008, they look at ventilatory strategy using low tidal volume, recruitment maneuver, and high positive high PEEP for ARDS. They found that there is no difference when you do recruitment maneuver in terms of how long the patient would be in mechanical ventilation, in terms of mortality. And it improves oxygenation, but it will not improve the outcome as we mentioned. For me, improving oxygenation is very good thing that I have to try, as long as it will not worsen the outcome of this patient. This is a systematic review and meta-analysis looking at recruitment maneuvers, and they look at the effective recruitment maneuver on oxygenation after 30 minutes of open lung ventilation. Open lung ventilation, that means I go do recruitment maneuver, I open the alveoli and keep the alveoli open with a higher PEEP, basically recruitment maneuver. And it showed that oxygenation get better with recruitment maneuver. And the confidence interval is basically doesn't cross the 1. Usually when you have the forest plot here, if it is in one side, that it favor that side. If it's not crossing the midline, it showed that the benefit of that side, it favor that side clearly. So it improves oxygenation. And if we look at the ratio between the dead space and the tidal volume, it favor the recruitment maneuver. So you improve opening of the alveoli, which contributing to the gas exchange. You decrease the dead space. You decrease the area which is ventilated, but not contributing to the gas exchange. And with that, you improve oxygenation. And again, from the same meta-analysis, they look at all patients with high tidal volume and no recruitment to improve oxygenation. They look at patients with low tidal volume and no recruitment. The BO2 will be better with recruitment, basically. So recruitment in general, it will help in improving oxygenation. This is basically the summary of the meta-analysis. They look at 926 articles. They included 16 studies, 836 patients, and they found recruitment maneuver increased oxygenation, decreased the displaced fraction, and the positive index parameter, the effect of PEEP, basically PEEP improve oxygenation and improve lung compliance with open lung strategy. Okay, next we will talk about airway pressure release ventilation. This is what we call non-conventional mode of mechanical ventilation or rescue therapy. Some people they try to use it, and if you look, it doesn't have a lot of utilization in ICUs because we're using low tidal volume, but it's something sometimes you may want to try after you know how it's functioning. This study published in Intensive Care Medicine 2017. They look at the early application of airway pressure release ventilation, and they say it may reduce mechanical ventilation days in ARDS. And they included patients with severe ARDS intubated more than 48 hours, but they don't have COPD or refractory shock or pulmonary hypertension. It's only 138 patients, mostly patients with pneumonia. And the airway pressure release ventilation, I'll show it later on probably for that. And they compare it with ARDS low tidal volume ventilation, the protective lung strategy. And they found that ventilator-free days within 28 days was 19 patients compared to 2, with statistically significant number. Successful extubation was 66 to 39. Tracheostomy was basically more in the low tidal volume, and death was mortality was more in the low tidal volume compared to the ABRV. This is the percentage of patients without assistance. It's more with the ABRV. And this is a systematic analysis. They look at airway pressure release ventilation during ARDS, and they look at ventilator-free days. And the ventilator-free days, it favor ABRV. As you can see here, the confidence interval doesn't cross the 1, and it favor the ABRV, and confirming the finding in the previous studies. If you look at the hospital mortality, it favor ABRV. If we look at VO2 FiO2 ratio, there is no difference between the two groups. Why we are not using it? There is no, it's only one study. And this study showed that a higher number of ventilator-free days and lower hospital mortality in hypoxemic patients treated with BRV than conventional ventilation without any negative hemodynamic impact or high-risk barotrauma. But this result to be interpreted in caution because of the evidence they consider it's low and moderate heterogeneity found. It's difficult to draw a message from this study, and still the ABRV, there is no adequate comparison between it and between the gold standard, let's say, of low tidal volume ventilation. In the future, I don't know what will happen. And basically, let me skip this slide and go to this slide. And what is ABRV? ABRV, basically, you set your ventilator into 4 parameters in addition to the FiO2. B high, B low, T high, T low. B high is the pressure at a higher level. So some people, they call it bi-level. So you have a high pressure level that usually set it around the mean airway pressure of the conventional mechanical ventilation or a little or 5 centimeters above that. So this is the B high. The pressure would be around, let's say, 30. And then the T high is the time that the pressure will remain this during this period. So let's say we have from 2 to 8, this is 6 seconds that the pressure will be maintained at a pressure of 30. And then we have the low pressure, which is the B low, which could be 0 or it could be 3 or 4 centimeter water, and the time is spent during this time, and this could be very brief time, which could be portion of the second or less than 1 second. And the idea of this, that during this period, it's similar to the inverse ratio ventilation. Basically, you do a continuous recruitment, continuous inverse ratio ventilation on this patient, but the difference that during this mode of mechanical ventilation, the expiratory valve will be open, so the patient can breathe spontaneously, and there are thoughts that during this spontaneous breathing, you recruit more alveoli. And as we say that the B low will be above the lower inflection point, and the B high will be below the upper inflection point. So we ventilate the patient with a safe method. For me, do we use ABRV? We don't. Why? We don't have the expertise. People that are not using it, we are not using it. And you don't have enough evidence to say it's better than the low tidal volume ventilation. Last part of my talk will be talking about high frequency oscillatory ventilation.
Khaled, if you allow me for ABRV, because our admin is asking many questions about ARV. He was very interested about ARV. You mentioned to Khaled about the experience of the ABRV. Do you see the difference? You mentioned in detail that the literature doesn't show difference and need expert. And the question, is there a criteria to select the patient who can get benefit from the ABRV? I think you agree with me, Dr. Khaled. We are saying always earlier will be better. So if you try him early, but expert experience, it could be better for oxygenations and improving. So do you have comment for him? Another question for him also, I think from our admin, the paralyzed. Did you need to paralyze the patient for ABRV? I don't think so. This is the one. Yeah, I'm with you, Dr. Khaled.
Okay, let's take it one by one.
Yes.
ABRV, who are the patients you select them for ABRV? Usually they select patients, they are not responding to conventional mode of mechanical ventilation. So people, they go for ABRV like some rescue therapy and non-conventional way. If you say, can we use it earlier? You can, but I don't know if you will leave the strong evidence for low tidal volume and you go for ABRV. Number two, إيش كان السؤال يا أحمد?
He's asking about the muscle relaxant, and you use muscle relaxant.
One of the advantage of ABRV that the patient can breathe spontaneously. So that means probably use less sedation, less muscle relaxant in these patients. But sometimes if the patient is severe enough and you could not ventilate the patient, people they sedate and ventilate the patient with sedation, but you lose the benefit of spontaneous breathing. And there are a lot of talk during spontaneous breathing, how the pressure will be going, how it will be, is it going to be high or low? But people claim that probably the recruitment of the alveoli will be better with some spontaneous breathing. There are a lot of questions, but there is no certain answer. And for me, you can ask me why you are not using ABRV. Number one, I will not leave the strong evidence for somebody with questionable evidence. Number two, when I put a patient on ABRV, next day I found it to be changed because people, they don't know how to use it. There are few tricks, there are few important things, how you adjust the ABRV to get the most benefit of the ventilation. So,
yes, continuous.
Yeah, so these are the two main reasons. Which patient will benefit? I don't know. You have to try. Okay. But again, let's imagine now you have a patient with ARDS and you elected to use ABRV and the patient died. Can you defend yourself? Do you have the evidence that this is better than low tidal volume? question to you, Ahmed, and the admin.
I think it's clear answer. In low tidal volume, Dr. Khaled is the only, maybe we have the trials which showing improving mortality in all ICUs is very, very limited, not more than 5 or 10 studies. One of them is low tidal volume. So nobody can argue with comparing low tidal volume or protective strategy with ARV.
This is why we're probably not using it. And I don't think people are interested to do more studies about it. This is the thing.
But yeah, if you allow me, Dr. Khaled, actually, I did use ARV for some patients, and as you have mentioned, and even when I'm reading in literature, there are some countries which is not countries, even some authors or intensivists, which is fan of ARV, which is limited, but the most of them not fan of that. But really, I think ARV went from the let us say art of rescue therapy, because adjustment of the ARV need clinical experience, especially the T-low. T-low is one from the very important point to be adjusted, because you can accumulate CO2, you can release the CO2, you can give low tidal volume, you can have tidal volume. It needs expert RT, of course, with intensivists to deal with ARV. But as mentioned by Dr. Khaled, the beauty of ARV is spontaneous breathing. So you are relying on contracting of the diaphragm, which is almost improving the collapse, especially of the posterior area of the lung, which cannot be done by any controlled mode. So ARV, and my own belief, is it good in good experience hand without, and also one from that, the patient will not improve dramatically within once you connect it. Usually you are connecting the ARV patient, you can find him shallow breathing, small tidal volume, give him 2 to 4 hours to have the effect. If you don't have the effect,
especially Ahmed, if the patient has hypercapnia.
Yes, usually this is the problem. This is the problem, Dr. Khaled, agree with you. The problem with the hypercapnia and dealing with that, one from the big problem, but you can deal with the adjustment very cautious. And if you connect him early, of course, you have to try low lung ventilation, protective lung ventilation first. Then before going with the more rescue therapy, if you try it early, you can find the benefit from that. But the benefit from that recruitment, work of breathing decrease. But if you don't find that, no, as Dr. Khaled mentioned, you have to block him down and knock him down and muscle accent and go with a different maneuver for rescue therapy. And also one very important point Dr. Khaled mentioned, you need 24 hours who's expert in dealing with that. In the morning, in the round, you can deal with that for few hours. You can find some improvement, start to recruit his alveoli. At night, maybe you can find the one who's very does like the way of breathing, CO2 increasing a little, so we'll paralyze him again and connect him back to another controlled ventilation. So with well expert hand, early patient dealing with the parameters, you can get benefit, but I think in clinical practice, you need the setting which can allow you to do that. I think the admin, we answered all of your questions about the ARV or for the yes, I think, Doctor.
As I mentioned, Ahmed, when the patient is not responding to initial setting of protective lung strategy and low tidal volume, you may try ARV early. If you would like to try, this is something you may consider. We mentioned earlier. And again, as I said, where is your patient sitting in the process of the disease? Is he early or late? The problem when you use ARV, maybe we use it when it's too late to wait, when it's too late to see some benefit probably. But is early is beneficial? I don't know.
Yes, I agree with you. I think the group of bi-level mechanical ventilation, whatever inverse ratio or bi-level or ARV, the same concept. I really, if you remember the head with the beyond the basic mechanical ventilation, the Chinese, we have it. They like this type of moods. But really, yes, as you have mentioned, you have to be expert enough to deal with bi-level, whatever the name, inverse ratio or bi-level or ARV, one of them, to have a good benefit from that.
Some people, they use the bi-level even for routine post-operative cases.
Yes.
And they thought that this is a good way to wean the patient quickly from mechanical ventilation, because because those patients, they have normal lungs. So your pressure will not be high. And when they start breathing spontaneously, they help and they will not fight, and then you can wean them quickly. But it is different from a patient with ARDS with very stiff lung. And
Yes.
what make things difficult, and the most of the difficulty I found with when the patient has hypercapnia, really, because even people,
Yes.
when they look, they could not tolerate low physician, they could not tolerate seeing a very low pH, and they could not control it.
By the way, the people, the fan of ABRV, they are taking the patient from time of initiation until weaning through ABRV. They have their own way.
Yes.
Okay.
Right.
Yes. Let us continue. Okay.
Okay.
Yes.
So the
Thank
high
you so
frequency,
much.
the high frequency oscillatory ventilator, it was a method that we use also as a rescue therapy. And let me go through it. So basically, the high oscillatory mechanical ventilation or ventilatory support, it has been used more by pediatric ICU, but they are expert in it. But we used to use this one as a rescue therapy. And what we have to do, basically, the breath will be a very, let's say, if you can see here in the diagram, this is a regular respiratory breath, conventional breathing. And during this period, you can see instead of one breath, you have, let's say, 60 breaths within 1 second. And these breaths are short. And basically, what you do, you get the breath here, and how you get a tidal volume, it's a displacement under this part of the curve of the breath, and I'm maintaining a mean airway pressure. So the ventilator, I set, if IO2, I set a mean airway pressure, which is the bias flow of gas will flow there, inflate the lung till I reach the mean airway pressure. After inflation of the lung, the ventilator will oscillate quickly with hertz. So hertz is 60 oscillation per minute, 60 oscillation. And then you can set the hertz to 2, 3, 4. But as you go faster, you reduce the area here, and then you reduce the tidal volume. If you would like to slow down, you increase your tidal volume, you increase your CO2 removal, and then you have the amplitude, which is basically the strength of each oscillation. And if you use a higher amplitude, and usually you set the amplitude to see some vibration at the mid-thigh of the patient, so it's like a hammer going and moving the air into the lung. And as we say, if you link this to the basic principle of lung mechanics, we thought that high frequency oscillatory ventilator is a ventilator, ventilate the patient in the safe zone between the lower and upper inflection point in the pressure volume curve. How gas, if I inflate the lung, how gas exchange will happen? There are different methods, different things, and probably you go at your spare time. There are different sites to tell you. There are different methods, which is, let's say, bulk convection, whereas more gas is entertained into the alveoli by the vacuum left when the oxygen absorbed into the capillary. So you have an alveoli contain oxygen. When the oxygen is absorbed by the capillary, there is a vacuum effect that would draw some more air. Or the Bindeloft, which is the gas exchange between the lung unit, which have different compliance. So you have an area alveoli with a low compliance and alveoli with a better compliance. So the gas will move from the lower to the higher compliance area. Tidal dispersion, which is the gas exchange between central rapid of oxygenated gas and the relatively oxygen poor gas at the periphery of the airways. So, or coaxial flow, which is a bidirectional flow of gas exists. I don't want to go to this quickly without, if I want you to understand it, it will take time, but you can go, you'll find many resources, many graphics to explain how gas exchange would happen. Because if you think, okay, I'm doing rapid frequency oscillation with mean airway pressure, and basically the air would oscillate, how gas exchange, this is the explanation. There are more than one method of movement of the air with this high frequency ventilation. Okay, this table, and it can be this table will tell you that these methods will be different at different airways. So in the proximal airway, this is the bulk flow. In the mid airway, it's Bendloff, Tyler dispersion, asymmetrical velocity profile. In the distal airway, it's cardiogenic mixing and collateral ventilation. Because even with ARB and high frequency, you can open some bridges between the alveoli and move oxygen between the alveoli. This study, it looked at high frequency oscillation in early acute respiratory distress syndrome. I think this is the study of Ferguson. He have a control group, I think, with a conventional mechanical ventilation. He looked at mortality, death in intensive care unit, death before 28 days. And if you can see here, 47% compared to 35%. 45 compared to 31, 40 compared to 29. So high frequency oscillatory ventilation have a higher mortality. Barotrauma, there is no difference. New tracheostomy, there is no difference. Refractory hypoxemia, maybe it improves oxygenation, the high frequency ventilation, and number of refractory hypoxemia is less. Death after refractory hypoxemia, 79 to 66. Refractory acidosis, there is no difference in refractory barotrauma. So basically, it increased mortality. And since then, if you look, this is the high frequency, the survival, the probability of survival is much less in high frequency oscillation. And this was the death sentence of the use of high frequency ventilation. And then at the conclusion of that study of Neil Ferguson, that in adult patient with moderate to severe ARDS, the early application of high frequency targeting lung recruitment as compared with ventilation strategy that use low tidal volume and high beep, and that permits high frequency only in cases of refractory hypoxemia, does not reduce mortality and may be harmful. And since then, we are not using high frequency, especially with the presence of Ecmo. This is Cochrane's library systematic review meta-analysis looking at high frequency ventilation. They look at different studies, and this table, just I want to illustrate for you. This is the mortality here, which is with a relative ratio of 0.092. No difference. Mortality at 6 months, there is probably no benefit of this. Let me go to the forest plot. It will illustrate it more. So in the forest plot here, mortality outcome, hospital 30 days mortality. If you look between high frequency ventilation and conventional mechanical ventilation, here the vent is 196, 192. So there is no benefit shown by using high frequency oscillatory ventilation to reduce mortality. And if we go again, I think this is, if I'm not mistaken, this is treatment failure. It's high treatment failure. So treatment failure, probably there is some tendency toward benefit favoring high frequency mechanical ventilation. But again, after that study of Neil Ferguson, we are not using high frequency ventilation. And now if the patient has hypoxemia or severe ARDS and need rescue therapy, after doing what we said in terms of using method of low tidal volume, high beep, some recruitment maneuver, Browning positioning, paralysis, and reducing volume, we go with no delay for Ecmo. So Ecmo showed probably it's a better option than high frequency ventilation, and we are not using it anymore. I think this is my last slide in the talk, and I hope I did cover, let's say, most of the ventilatory part of management of ARDS with shedding light on basic and connecting the basic to the clinical application, clinical trials, and we reviewed probably the evidence. For time constraint, we could not show all the evidence in detail, but these are the points that we talk about it, and I'm happy to have any question to be answered.
Well, thank you so much, Dr. Khaled. A very comprehensive review for the ARDS, and I'm really happy that you mentioned the high frequency, especially with the oscillation and the oscillator trial, which is almost killed the high frequency. But if you remember, almost like 7 years back or 8 years back, we have a very huge patient experience with high frequency. And our center, as you know, we have a lot of devices, and we did use it a lot as a rescue therapy. And even we have seen a lot of hypoxemic improving for the patient, hypoxia improving. But of course, with the evidence-based, we can say now in the shelf, nobody using it, apart from the neonates, of course.
Yeah,
but
I think
I
the
do like
is different. Pediatric and neonate, I think they have some application of high frequency.
Yes, yeah. But even though on the ground, on the floor, we did use it, and we chose some in front of eyes, and some of the improvement in hypoxemia for the patient as a last resort for the patient who cannot improve their oxygenation by the traditional or even rescue therapy. But of course, the evidence always have superiority for the managing with the patient, because it is worldwide and they are dealing with that. For the high frequency, thank you so much. If you have any question for the audience, you can just put it in. You can drop your question in the chat room.
Or if somebody would like to talk, Madri, if you want to allow somebody, I need to use.
Yeah, if you'd like to mic, use and can talk, you can open your mic and ask. Greatly welcome. Dr. Khaled, of course, the ARDS, like any other disease in the ICU, especially the most common disease in ICU, and like ARDS, have a lot of literature and the evidence and everything. But you agree with me that the new trend about personalization or individualization, to say whatever, or precision medicine for ARDS or for management, it is on the floor nowadays worldwide, even not in the clinical practice, because everyone has his own course figures, parameters, different lung mechanics, different physiology, different parameters. I am as a user, I do like even to give me a numbers to follow up. For example, if you tell me go with the tidal volume 4 to 6 to ml, I will be happy. I will be almost satisfied. If you ask me to give my plateau pressure 30, I will be happy and easy to be used, right? But if you tell me each person has his own tidal volume, each person has his own plateau, yes, of course it will be like
I think Ahmed, what I say that as a person dealing a specialist in critical care, you should look for mechanical ventilation for every patient individually. No patient like the other. Some patient they will like higher PEEP, some patient they don't like high PEEP. Some patient they like tidal volume at a higher level, because some of the recommendation, if you set a tidal volume at 6 and then the plateau pressure less than 30, you can go to a higher tidal volume, for example, 7. So there are a lot of things you will not learn it, you will not test it, you will not see the benefit unless you stand side the bedside and you play with the mechanical. But you should not play with mechanical ventilation unless you know what you are doing.
Yes, I agree with you. So the bottom line, in the beginners, it is better for you to have the protocol, to have the number to follow up. But once you get experience, you can deal with your own personalized management. This one, by the way, for all disease nowadays, because everyone has his own phenotype, everyone has his own lung mechanics, his own basic parameters. Especially, we are dealing with the anesthesia, so for easy for the anesthetist to have a brief visit clinic before he will go for OR, so you know where the baseline of each patient. But for ICU, unfortunately, we have the patient on the spot on the bed, right? So we don't know his baseline.
Let me prove Ahmed to have a short comment about this precision. For example, post-operative nausea and vomiting. Nowadays, some people search that is related to some genes, so should be personalized as you want. Your question, أنا كنت بفكر أسأل دكتور خالد المغربي فيه، هل هيجي وقت في برسيجن ميديسن هنقول إن العيان ده عشان ما يحصلش بيزار ريسبونس في بين لو تايدال فوليوم في الديفرنت بيشنت، ده سيوتبل ليه ان احنا نعمل كده، وده لا نعمل اللانج استراتيجي بالشكل الفلاني او الريسبوندنج احسن؟ هل ده هيبقى جين ريليتد بعد كده؟ هل ده اللي انا كنت عايزه اساله وحضرتك سالته قبل يعني؟
It could be, but the gene related will be related to the pathogenesis and how the patient respond in terms of the pathogenesis. Like if you look at sepsis, for example, if you look at a patient who are developing septic, who is the patient, for example, have E. coli and develop sepsis, there are certain genetic abnormality related to the innate immunity in these patients. So probably the pathogenesis will be different, the affection will be different. How we can learn from COVID, they have more of the thrombosis. I mentioned that in the ARDS, you have some thrombosis in the capillary, and COVID is more. So the genetic predisposition to have more element of a disease rather than the other one, definitely, but I don't think it is, I'm not aware if it is studied, but I think the literature is wide to search for it.
Maybe the coming days will solve this problem.
Agreed, Dr. Safa. Actually, you know, as Dr. Khaled mentioned, the genotyping, or let us say phenotyping, or biological one, from the factor of personalization. And the personalizations in the ARDS have a lot, like target tidal volume, like recruitment, like gas exchange, like even the plateau pressure, different for each one, right? For lung mechanics as well as, of course, genotyping. فالphenotype hyper inflammatory, hypo inflammatory, one from the item of personalizations, but of course, as Dr. Khaled mentioned, still this is the era of research for the future. I think we have to have it.
Yes.
Going back, Dr. Khaled, for the attendees, we have one question about non-depolarizing muscle relaxant, neuromuscular blockers for the ARDS patients.
The latest evidence support its utilization for the first 72 hours. There are the study. There are some conflicting results, but now, as I mentioned, nobody will go, for example, for Ecmo before trying muscle relaxant and proning for that. I don't remember the evidence, but as far as I remember, ممكن تذكرني يا أحمد إنه the first study showed that it is beneficial within the 72 hours, and then there is another study did not show the same significant outcome. صح يا أحمد?
Yes, they can about muscle relaxant. If I got this, they can use the only trial showing that cisatrachyurium used for 48 hours, maybe in some patients, 24 to 48 hours, it's showing some mortality benefit during that time. But I'm believing in it, and because it was strict to cisatrachyurium, which we are not using, so still have a rooming, but I don't think so. It is not like other modalities yet. So if you cannot ventilate the patient, you can give him, and as much as you can, to minimize the muscle relaxant in ICUs. We have debating questions about Khaled fear.
Can you hear me?
I have a comment.
Yes.
Yes. Hi. Assalamu alaikum. Dr. Khaled, Dr. Safa, Dr. Ahmed. Thank you very much for this comprehensive presentation. And I think you mentioned all about the mechanical ventilation, really strategies, but I just want to also comment that the patient is as one unit, integrity. The other factors is very, very important. The negative balance, the fluid balance, CRRT, fluid removal, infection control. Also, this is really, really important in the management, because at some point, these factors contribute more and is very harmful. I remember, like septic patients, when they start fluid resuscitation, usually this reflects definitely on the lungs. Soon the next day, 24, 48 hours, they will be flooded with fluids, and then the ARDS happen after the sepsis because of this. I remember, we used to give fluids, and then the next day, patient go into ARDS, we give lasers. So this has to be in the context of the management of these patients. Is very, very important. The same as you mentioned, the ideal body weight Yeah.
Yusuf, as I said, initially you need to have the alveoli distended with air. So if you can't reduce the amount of fluid, so it's the same principle. So dry lungs are happy lungs. We do agree, but the things that I wanted
this
to
is what
talk about.
intensivists always saying, Dr. Khaled, but nephrologists they have another, huh?
Yeah, but this is I wanted only to talk about mechanical ventilatory management.
That's why.
Not the other things.
Yeah, exactly. Yeah. So one thing also you mentioned, the ideal body weight is very important, and also looking at the background of the patient is very also important, because I mean, if you are ventilating a patient who is like restrictive lung disease before lung fibrosis, it's different than COPD and different. So this is also like the background of the patient is very important. And also I don't know if we can label patients who are long-term ventilated when they become more sick, more hypoxic. Is it you treat them the same as ARDS if they become sick and hypoxic or any infection on top? Because sometimes these long-term patients are really challenging. You mentioned about tracheostomy patient, and even you mentioned about maybe Browning's. So because I have some patients, like we have some of these patients in our ICU, and they get worse and come back and forth from LTC long-term to our ICU. I don't think it's the pathophysiology also the same as a healthy lung pneumonia, new COVID.
Definitely. I mean, if you have a patient with interstitial lung disease and you don't know what you are doing, so what we talk about from the basic science, how the lung will be distributed, how the alveoli, there is more complex situation. But in general, what has been proven with no doubt, the injury to the alveoli, the villi, is there, whatever is the pathogenesis. So if you can ventilate your patient with lower pressure, if you can ventilate patients safely, keeping the plateau pressure, which is, we think it is the pressure reflecting the pressure in the alveoli, definitely you do better for anyone. Normal lung. So I think low tidal volume, the guidelines for low tidal volume, basically it is not going to harm the diseased part of the alveoli. It may increase the injury. So it injured the alveoli, which is the normal alveoli and the abnormal alveoli. You can induce lung injury in normal people with a very high pressures, because as we said, you have the barotrauma before you go to a clear alveolitis or a clear ERDS. So I am a believer and a strong recommender that use the lowest pressure in patients. Even if the patient has normal lung, use the lowest pressure. Higher pressure, it may damage the alveoli. And as I said, you have to individualize. If you have a patient, for example, with interstitial lung, it is one among the things that will be really difficult to work and predict. Again, personalization. You sit beside the patient, you see what you can do, how you reduce the harm to start with, how you get a reasonable gas exchange, and you take it from there.
Yes, thank you very much. Yeah, that's clear.
Thank you, Dr.
Ashraf,
Dr. Khaled.
Thank you, Dr. Ashraf.
We still have
I have a comment. في question ممكن اقول comment بس كده.
اتفضلي يا دكتوره. اتفضلي طبعا. اتفضلي
بعد اذن حضرتك. يعني I suppose that برضو ان الارتفيشال انتليجنس هيدخل لنا في نفس الاريا. بعد كده لما احط الداتا بتاعت العيان دي وانا هسسبكت ده اوف جود بروجنوزس او لا، على حسب طبعا البريشر وعلى حسب الباثولوجي اللي موجود وحسب الكوموربيديتي وحسب البوزيشن اللي انا حطيت فيه الفنتليتور. Dr. Khaled, you suppose that artificial intelligence and machine learning will have a role in management of ARDS in the coming few months or years?
Yes. What I can tell you, if you look now at artificial intelligence in critical care medicine, among the things that artificial intelligence using basically data from previous patients, and what it can be used to predict patients who's going to be worse or patient will have a better or worse outcome. So probably predicting who's the patient going in the wrong way, artificial intelligence, I think it will have a part, and you will see it in the future in predicting how the patient will behave. Is the patient going to improve or not? Is the patient going to collapse? Is the patient going to respond? And basically dealing with the data from the patient and for the system. I think for my limited knowledge, I will not be surprised that it will play a major role in the future.
Sure, Dr. Khaled, I think this is the future. Will be the human, they will have nothing to do. But
no, they will not discuss. Don't worry.
No, anesthesiologist or intensivist.
But I think in our clinical practice, even if you go back to our smart modes, we still have some of the device which can play some role. You are just giving the stated minute ventilation, and they can adjust the rate, they can adjust the, of course, adaptive, and most of the smart modes now playing the role of some of that.
They try to overcome, they try by the artificial intelligence, they try to overcome some cognitive dysfunction because of our busy or because our expanding our effort. So they want to do this artificial intelligence to overcome this point only. Yes. And they will not succeed.
Human errors. I agree with you. Yeah. I think we have a question for the steroids. This is, I think, the very debating and long questions. For the steroids in ARDS, Dr. Abdullah asking.
I think there is till now the evidence of a steroid is not supported, and in my practice I don't practice. But as long as Maduri is still alive, we can see more trials for steroid to be used.
But we did agree for the high dose there is no place, right, Dr. Khaled? But for the small dose, still debating.
There's still debating. So there is strong debate, and I don't know. I'm not using it in my practice. My colleague in my hospital, we are not using it, and probably
Midori and Anan, a lot of fan of the steroids, and others against.
There is a recent study for Midori looking at sepsis with steroid, but it was negative again.
Yes, yeah. So a lot of conflicting, but at least the high dose nobody using nowadays. There is very experience, Dr. Khaled, from also admin, the question about extracorporeal carbon dioxide removal. I'm really witness of the Saudi Arabia experience for the Ecmo. They have a lot of achievements for the Ecmo. And about extracorporeal carbon dioxide, do you have any data, Dr. Khaled, about it for the patient with
well, I don't have data. The extracorporeal CO2 removal, there are more than one method that can be done. One of them through the Ecmo machines, similar to the Ecmo machine, using basically smaller cannulas, smaller flow, and different oxygenator or CO2 removal, which is expensive. People, they use what they call the Nova lung, which is basically you hook the CO2 removal, let's say, filter without machine between an artery and vein of the patient, or to use something through a dialysis catheter. The experience is not huge. I think patient population will determine this, but for myself, I don't have experience. For myself, when I was chairman of the department, we got 2 of the Nova lung, but they expired before we used them, and they are quite expensive.
Yes. Another last question, I think, about timing of Ecmo. Of course, this is it is not one from the rationale of objective, but the best time for Ecmo to be effective.
The Ecmo will be effective. Yes. Definitely, at any time, Ecmo is effective. But when is the time you catch the lung for a possibility of recovery? This is the issue. So the Ecmo is effective in any time, but you would like to support the lung which has some reversibility. So that means you go early in these lungs. Let's say the patient should not be on harmful mechanical ventilation, or you are not able to do protective lung strategy just for, let's say, less than a day. If the patient in maximum, you paralyze the patient, you prone the patient, and then he's not improving, you should not wait longer, because Ecmo, the patient will be fine on Ecmo. Definitely, you will have beautiful number, beautiful oxygenation, but the lung recovery is the issue. So patients should not be long time on. What's the long time? We're talking about 24 to 72 hours maximum.
I think we did agree. And the protocol of ECMO in Saudi Arabia is very clear, right? You have specific objective parameters to be activated the ECMO. Even the ECMO team, when deactivated, they advise to go through the protective strategy, to the recruitment, to the but within certain time. Yani first go with the talk about ARDS ECMO. يعني ABRV, sorry, Browning recruitment within short time. If failed, they are taking the patient for ECMO. I think.
Okay, I think we answered the question for the ECMO. Any other question or comment?
I don't think so. The chat room, I think, is empty with a lot of thanks. So I'd like actually to thank you, Dr. Khaled, a lot, so much for very, very comprehensive review. Yani, I'm really refresh all of our memo about the ARDS from A to Z. Thank you so much, Dr. Khaled. Floor is yours, Dr. Safa, and thank you so much.
Okay. So proud and so grateful for Dr. Khaled Maghrabi. Really, no enough words can express my feeling and appreciation. We spent about 2 hours. We have even no 1 minute to attention distraction. Thank you, Dr. Khaled. Exactly, as long as the time passed, we are more attention and we more concentrated with you. Every word in your lecture leave a deep print in our experience and our daily practice. Of course, we have a very valuable and comprehensive lecture. Thank you, Dr. Khaled. Really, and lastly, Dr. Khaled, it is my great pleasure and appreciation for your valuable time and effort. Many thanks, and please repeat this chance for us again, please.
Thank you for inviting me, and inshallah يعني أتمنى من كل قلبي إنه everybody get the benefit of you.
إحنا طمعانين في حضرتك تاني إن شاء الله في الوقت اللي حضرتك تحدده إن شاء الله بإذن الله.
إن شاء الله خير.
إن شاء الله.
شكرا يا دكتور. شكرا لكم وشكرا للجميع الحاضرين.
Dr. Ahmed Madi, really you are an amazing moderator. You manage this heavy meal session cleverly and promptly. Many thanks for your valuable time and effort. And if we have a chance to have you, and really it is a good surprise for me firstly and for all my attendees that you will be with us the last Friday in sweet November. We are waiting for you, Dr. Ahmed, and many thanks for your valuable time and effort, both of you. And I know that يعني زي ما أنا قلت في البوست إن السيشن دي هتبقى علامة وعلامة من 2 علامة. فشكرا جزيلا لحضرتك دكتور خالد، شكرا جزيلا دكتور أحمد، وإن شاء الله تنعاد علينا كلنا الأيام بخير.
شكرا جزيلا.